Awesome. So we're going to talk about this deep vein dilemma, right? So treating VTEs in athletes and how that treatment goes and kind of recommended guidelines on return to sport. And while there is some controversy here, there are some general principles to know and when to recognize and how to appropriately work that up and kind of guide these athletes back to their sport, right? So we'll kind of jump right into it. Um, so I have no financial disclosures for this talk. Um, in talking about VTEs, it's important to understand that this encompasses both deep venous thrombosis, which is a DVT, and a pulmonary embolism, right? We're going to focus more so on treating the DVTs, but understanding that this can ultimately progress to a pulmonary embolism, which ends up being more of an emergent diagnosis. It's important to remember that pathophysiology that in turn creates these clots, right? So if you remember from medical school training, Virchow's triad is kind of that general core principle that we think of the clot formation, right? So that combination of hypercoagulability, venous stasis, and endothelial injury that can all lead to the formation of a thrombus. And while this is definitely a little bit more common in the general population, it does affect our athletes, right? The literature supports that about 1 in 1,000 athletes are found to have a VTE and does carry a high risk of morbidity and mortality. So it's important to kind of recognize and know the appropriate kind of treatment and workup for this. And then further kind of diving into it, right? It's important to understand that there are different risk factors that go into VTEs. And so we kind of break them up into this inherited risk factor and this acquired risk factor, right? So your inherited risk factors are going to be more your natural deficiencies in your anticoagulants. If you have any underlying genetic deficiencies or factor five Leiden mutations, and your acquired risk factors are going to be those ones that the athlete or patient acquires throughout their life. So maybe some malignancy, antiphospholipid syndrome, extrinsic risk factors like drugs, smoking, obesity, pregnancy, surgery, or major trauma. And then there's some specific kind of athlete specific risk factors that are important for us to recognize, right? And that kind of highlighted here and how they fit into that Birchhouse triad. So, one, thinking about venous stasis in our athletes, right? So, athletes, as we know, have a lower resting heart rate and often lower blood pressures, which puts them at risk for more venous stasis. And they often undergo long travel trips. They may have uh, surgery that puts them at risk for more venous stasis that can put them at risk for developing blood clots. They might be a little bit more hypercoagulable because they're more prone to bouts of dehydration or episodes of overtraining. If they're a female athlete who's taking oral contraceptives, just like in our general population, they may be at a higher risk for hypercoagulability. And then if they're repeatedly undergoing changes in altitude or using any hypobaric chambers, that can put them at risk as well. And then thinking about kind of more vessel wall injury, right? So athletes undergo a lot of repetitive stress, a lot of repetitive injury, and that can put you at risk for endothelial wall injuries. And so together, these are kind of more of those athlete specific risk factors that we have to be aware of and have to constantly think about. And so then the important distinction becomes whether this is a provoked event or an unprovoked event. And the reason why this is important is because it's going to guide our treatment when we're thinking about treatment options for these athletes, right? So a provoked event is going to be one that has a strong transient risk factor. So in our general population, we generally think about these as some sort of major surgery, some sort of major trauma, whether they've been hospitalized or immobilized for a period of time. And then in our athletes, this is going to be more so a DVT that's associated with one of those specific risk factors that we talked about. So some sort of event that then leads to them developing a blood clot. An unprovoked DVT is exactly what it sounds like, right? So an event that doesn't have a clear trigger, nothing that you can truly point to say that that likely caused their injury. And then obviously important to recognize the clinical presentation and how these are going to present. So they're typically going to present with this unilateral extremity plane swelling, maybe some erythema, and important to have a high degree of suspicion because oftentimes these can mimic a muscle injury or a muscle strain. So making sure you're having that in the back of your mind to always consider. Obviously, pulmonary embolisms, just to kind of go along the spectrum, are going to present with more significant symptoms of chest pain or shortness of breath, tachycardia, and hypoxia. Uh, And so when we think about lower extremity DVTs, right, it's important to be familiarized with the vasculature and understanding the differences between a proximal and a distal DVT, right? So an easy way to think about it is kind of thinking about above the knee being more of a proximal location and below the knee being more of a distal location. And this again is going to help us kind of guide management and treatment going forward. And so it's important to when they look at kind of systematic reviews and in what athletes are at higher risk for these, it's shown that we see these more in soccer players, endurance athletes, martial artists, and in soccer players and martial artists, it could be due to that repetitive lower leg trauma that they're experiencing throughout their play or throughout their sport. Endurance athletes like runners, it's going to be more that repetitive micro trauma or sometimes that venous pooling as well too that can put them at a higher risk. And then some of the symptoms that we already talked about. For upper extremity DVTs, it's important again to familiarize yourself with the deep vein structure as well as the superficial vein structure, right? Because superficial vein thrombosis are not going to be treated the same and most oftenly are not going to require significant anticoagulation or treatment. But understanding where these deep veins are located um, and when to recognize whether an athlete has a deep vein thrombosis of the upper extremity. Looking at review studies that look at the pathogenesis for these upper extremity DVTs, it's actually more commonly a secondary cause in the general population, right? So something associated with catheter-associated thromboses, cancer-associated thromboses, or uh, shoulder trauma, or surgery of the upper extremity. But in our patient population, so in these athletes, we're thinking about these primary causes. So more so venous thoracic outlet syndrome or effort related thrombosis. And they also kind of lump in this category of just kind of idiopathic, right? So kind of focusing in more on these effort thromboses is one disease entity to be familiarized is this Paget-Schroeder syndrome, right? So this is where you have a clot that forms in the subclavian vein, and it's going to be more common in these athletes that are involved in these repetitive overhead activities. Most commonly seen in the review papers that I looked at in baseball athletes, specifically pitchers is where it's seen more so, weightlifters as well, and then less commonly in but still more than other athletes in swimmers, football players, basketball players, volleyball players, and wrestlers. Really, you're going to consider it more in these athletes that have that repetitive overhead activity that can put them at risk. It's going to present with more kind of acute pain and swelling and even discoloration to the area of the upper extremity. And you can see these dilated collateral veins, which is called an Urschel sign. And then when we're considering this diagnosis, it's important to understand the workup and the evaluation for it, right? And understanding the sensitivity of our testing that we do for it. So we're all very familiar with ordering a venous duplex ultrasound when we have consideration for this, but understanding the sensitivity, it's very sensitivity for proximal lower extremity DVTs and pretty sensitive for these upper extremity DVTs as well. Where we start to lose some of that sensitivity is going to be in these isolated distal DVTs of the lower extremity. And that's where if you have a high degree of suspicion where doing multiple serial ultrasounds is going to be able to eventually pick that up and be able to help you with that diagnosis as long as you maintain that high degree of suspicion. Obviously, if you're more concerned for a pulmonary embolism, the gold standard testing is going to be a CT pulmonary angiogram. And then laboratory testing is where there comes to be a little bit of a gray area, right? So common tests that are going to be ordered when you have an athlete with this are going to be a CBC, ESR, um, coags. And then when you're thinking about when to do thrombophilia testing, right? The literature supports doing it in young athletes or young age individuals who are less than 40, patients who have a strong family history of VTE, or a VTE with weak provoking factors, or in the event of a recurrent VTE. It doesn't necessarily change our initial management, which we'll talk about, but in most athletes are going to consider doing this thrombophilia testing to see if they have any other underlying kind of inherited risk factor. And then when we start to think about treatment for it, right, which is the focus of what we're focusing in on tonight, right? Um, the general recommendations for treating a DVT in a patient or an athlete is understanding whether this is provoked or unprovoked, right? So in a provoked proximal DVT, so those ones with those strong transient risk factors, the treatment is really going to be a 3-month course of anticoagulant therapy. And the treatment of choice is going to be one of these direct oral anticoagulants, so your DOACs. And that's truly because they have a shorter half-life, they have more predictable pharmacokinetics, and allows for greater flexibility with treating these athletes. Um, for a provoked distal DVT, there is some leeway here. If they're asymptomatic, you could consider close observation with serial ultrasounds to see if that clot reabsorbs. Um, but if they're symptomatic, meaning they have any sort of pain or significant swelling, then the recommendation is still to start them on anticoagulation. And then for unprovoked DVTs, this is where it gets to be tricky, and where they may need indefinite anticoagulation, and ensuring that you have specialists on board to help you out, such as hematology, is likely going to be needed in these kinds of scenarios as well. And then when we talk about acute upper extremity DVT, so again, in that Paget-Schroeder syndrome that we talked about, the recommended treatment really is going to be this catheter-directed thrombolysis. It's been shown to be most effective if it's done within the first 14 days of symptom onset. Um, and then it's usually followed by a surgical thoracic outlet decompression, which is going to be a resection of that first rib. And in studies where they've looked at multiple athletes, one of which that I looked at in about 140 athletes in a journal of shoulder surgery, they saw athletes that were treated with surgical intervention had about 84% likelihood to return back to their original lifestyle and sport activity, versus athletes that were treated with only anticoagulation or direct thrombolysis. Only about 40% of those were able to kind of return back to their original sport activity level. So the literature is really supporting pursuing more of this surgical decompression after the directed thrombolysis for these patients. And then return to play guidelines, right? So it's really important to understand that there's limited high quality evidence in the way that this is typically done. It's typically an individualized um, return to play program for each athlete, right? And so the idea behind doing this is that understanding that you don't want to allow them to go back to any sport while they're playing, while they're on anticoagulation, for those first 3 months. And really, most of the recommendations say that you shouldn't go back to exercise within the first 2 to 3 weeks when starting the anticoagulation, and that's to allow that clot to stabilize. They've done randomized control studies to look at the exercise in athletes who have started on anticoagulation. And really, at about 5 to 6 weeks, it's definitely shown to be safe. But some more expert opinions and review papers have shown that 3 weeks is probably about safe for these patients. After 3 weeks, they can resume non-collision fitness training. So anything where they're not going to be at risk for having a collision injury. And then after 3 months of continuous treatment with resolution of symptoms and without any residual clot burden, they can safely transition off of anticoagulation and resume their sport activity. Now, in the case of athletes that may need indefinite anticoagulation, right? So these are going to be those unprovoked VTEs in athletes, or those athletes who are have a recurrent VTE, right? That's where the recommendations are definitely limited, and a lot of the research here is more so done with position papers and expert opinions on how to do this. And one of the mainstays behind this is understanding that this has to be a shared decision making process between the athlete, the team physician, um, and involving specialists on board, such as hematology and cardiology, is recommended, and making sure that they understand through an informed consent the risks of being involved in this. And there aren't really recommendations on essentially what to do with this, but the position papers that have been put out have shown that they recommend a strategy that can be done. And there has been some athletes that have done this in professional sports successfully. The first line choice that they recommend is still these DOAC medications. Low molecular weight heparin is an alternative as well. Has a little bit of a shorter half-life than the DOACs, at about 7 hours compared to about 12 hours with the DOACs, and some athletes have done that in the past. The way they recommend doing it in these expert opinion papers and these position papers is a strategy that's developed for non-contact sports, right? So for swimming, badminton, moderate intensive running, they recommend on days where you're going to do a prolonged practice or a game day that they would skip their morning dose of anticoagulant. And then if no significant trauma occurs, um, they can next scheduled dose can be resumed. But if a trauma does occur, then they would hold it for about 24 hours. In contact sports, right? So sports like cycling, boxing, rugby, baseball, soccer, hockey, it's still recommended to undergo this twice daily DOAC regimen. But on game days or contact practices, no anticoagulation would be given at all. And then, regardless if there is a trauma or not, they're still held for about 24 to 48 hours after a game or some sort of contact practice. And that's due to the risk of a potentially silent injury. And again, while is a suggested protocol, there's other studies that are looking at kind of the pharmacokinetics behind doing some pharmacokinetic testing to see when enough of the drug has left the system when the patient can kind of return back to the sport safely. But this position paper offered about this 24 to 48-hour period. Um, they recommend having checklists done with the athlete after practices, and before games and after games as well too, to kind of keep track of their symptoms. And like I said, there's been a couple of occurrences of this done specifically in the NHL. Um, Several years ago, there was a couple of athletes, one that used low molecular weight heparin safely, um, and some other occurrences too, but it is definitely less common. And that's pretty much it.
All right, Matt, Dr. Apicella's super talk. Great topic, and I think fortunately, we don't see these that often in the office setting, but we definitely do see them. So really great information, and I know for me, just like you said, it's like about getting some of the more specialists involved, and but really a great talk, great information. Thanks so much, Dr. Apicella.